by Professor Surekha Bangal and Professor Shobna Jorvekar, for both professors at Pravara Medical College in Pune. We also have another case of developmental cataract, which is going to be presented by Dr. Viram Rajput, who's going to be mentored by Dr. Charita Manke from Cooper Hospital. We have two distinguished faculty members along with us, Professor Suhas Haldipurkar sir, who, as we all know, needs no introduction anywhere around the country. He is, of course, the founding chair of Lakshmi Eye Institute in Mumbai, and a stalwart and expert surgeon and teacher to most of us. And we have Professor Meenu Ramakrishnan, she's professor at KJ Somaiya Medical College in Mumbai. And with this brief introduction, I'll hand it over to Dr. Shreesh Parat sir to give his opening remarks, and further on to our dynamic member of the scientific committee, Dr. Archana Ware, and Dr. Sumit Lhane, to carry the program forward.
Thank you. Thank you very much. Thank you very much. On behalf of MOS, I welcome you all for this PG program. And I really thank all the mentors and presenters for their participation. Friends, I feel very proud that our scientific committee has provided a very good platform to all these budding ophthalmologists. And I feel very happy for the students as they are being mentored by the experienced teacher, and they get to learn from the faculties of different institutes throughout the India. My heartfelt gratitude to expert panelist, Dr. Meenu Ramakrishnan, and our own teacher, who is a pioneer of phaco in Maharashtra, who is known for his academic excellence and surgical elegance, our own Dr. Suhas Haldipurkar. So friends, let us continue with the program. I wish Anisha and Viram all the best for the presentations. I'm looking forward to insightful presentation. Thank you. Over to you, madam.
Thank you, sir. Good evening to everyone. Special good evening to Haldipurkar sir and Meenu ma'am for accepting our invitation, and we are so lucky to have you, sir and ma'am, here. So the format of the program is 8 to 8:30 there will be one first case presentation, and 8:30 to 9 there will be second case presentation. So the first case will be presented by Dr. Anisha Wagh. She is a junior resident at Rural Medical College, Loni, and she is mentored by Surekha Bangal ma'am and Shobna Jorvekar ma'am. And Surekha Bangal ma'am, she was my mentor too. So really lucky to have you, ma'am. And now I request Dr. Anisha to start her case presentation. So please share your screen, Anisha.
Thank you, ma'am. I hope my screen is visible. Good evening, everyone. I would like to begin by thanking the team of MOS for this opportunity and platform, and I would also like to thank my mentors for their guidance and support. A 7-year-old female was brought to our OPD by her mother with the complaint of diminution of vision in the right eye since 8 months. According to the mother, she was apparently all right 8 months ago when the mother noticed that she was not able to see the television from far, and the school teachers had also noticed that she was unable to see the blackboard from the back of the class. The diminution of vision was gradual, painless, and progressive, and there is history of spectacle use since 5 months. There was no history of any headache or ocular strain, no history of ocular trauma, no history of any hearing problems or cardiac issues. There was no history of intolerance to milk or other dairy products, lethargy, vomiting, or diarrhea, any skin diseases, weakness of proximal muscles, abnormal gait, or exposure to radiation. The antenatal history, the mother received routine ANC care, and there was no history of any vaccination prior to the pregnancy. The mother did give history of an inability to eat, weakness, and poor diet in the first trimester of pregnancy, and there was one episode of syncope in the 3rd month for which she was given some intravenous fluids. There's no history of fever, rash, any other drug intake, or radiation exposure during the pregnancy. The child was born at full term by normal delivery and no history of prolonged labor. She weighed 1,000 grams at birth and cried immediately after birth. She was kept in the NICU for 1 month for observation and weight gain, but there was no history of any supplemental oxygen therapy. The child was breastfed immediately after birth, which continued till 1.5 years of age. Her milestones were appropriate in comparison to peers of the same age, and she had a good academic performance and social interaction. Immunization was complete. She had history of similar complaints in the left eye, for which she had undergone evaluation and was diagnosed to have cataract. As per the available reports, she underwent a phacoemulsification with a foldable posterior chamber intraocular lens implantation 5 months ago. No history of any other surgeries in the past. The mother did give history of her taking calcium supplements 3 years ago for a period of 1 month as prescribed by a pediatrician. However, they had discontinued the same without any medical advice. The patient is currently not on any oral or topical medications and has not taken any topical medications in the past. No known history of any drug allergy. The child is born out of a non-consanguineous marriage and is of second birth order, and there is no history of any similar complaints, use of thick glasses, or any ocular surgery in the parents or either siblings. Her sleep is normal, appetite is less than normal, with a mixed diet, and bowel bladder habits are normal. She's thin-built, poorly nourished, and is conscious, cooperative, well-oriented in time, place, and person. On anthropometry, her height, weight, and BMI were all less than -3 standard deviation for her age. She's afebrile with a pulse of 88 per minute and 18 breaths per minute is her respiratory rate, with no signs of pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. On systemic examination, the cardiovascular system, there was S1, S2 sounds present with no murmur. The air entry was bilaterally equal with no vesicular breath sounds, and no neurological deficit was noted. The abdomen is soft with no guarding rigidity or tenderness. The musculoskeletal examination revealed no bony deformity and a grade 4 power in all 4 limbs. Skin and dental examination was normal. Head position is normal. Facial symmetry was present. The child is orthophoric with a central Hirschberg reflex in both eyes and no movements on an alternate cover test. The ductions and versions in both eyes are full, free, and painless in all directions of gaze, and no nystagmus was present. The lacrimal sac in both eyes was clinically patent, and intraocular pressure on Goldman applanation tonometry was 16 millimeters of mercury. In the right eye, her uncorrected visual acuity was 636 N18, which did not improve on pinhole. And retinoscopy, we saw a dull reflex due to a central lenticular opacity. In the left eye, her vision was 636 N18, which improved to 69 on pinhole. These are my retinoscopy findings with dry retinoscopy done at a 1 meter working distance. On correcting further for the distance, she gave an acceptance of +2 diopter sphere and -1.75 diopter cylinder at 180 degrees and a near addition of 3 diopters, with which she improved to 69 N6. Anterior segment examination on slit lamp, where torchlight findings were confirmed on slit lamp examination. The eyelid overlying skin was normal, margins were well opposed to the globe, and there was normal arrangement and direction of lashes. Conjunctiva was normal in the right eye. Cornea was normal in size, shape, surface, sheen, transparency, and sensations. Anterior chamber was normal in content and depth with a Van Herrick grade 4. Iris had normal color and pattern. The pupil was 2 millimeters, single, circular, briskly reacting to light with a direct and consensual light reflex present. On examination of the lens after dilation of the pupil, on diffuse illumination, a lenticular opacity occupying the central 4 millimeter zone was seen with a peripheral clear zone. Small linear opacities like the spokes of a wheel were seen radiating towards the equator, suggestive of riders. On direct illumination with an optical section, the opacity involved the infantile nucleus and the deeper part of the cortex. Examination of the left eye revealed normal lids and conjunctiva. There was a 3 millimeter scleral groove seen at the 12 o'clock position, 1 millimeter behind the limbus. Cornea was normal, and a 3 millimeter inner lip of scleral tunnel was seen superiorly, and a side port scar was noted at the 9 o'clock position. Anterior chamber was normal in content and depth, and the iris was normal in color and pattern. The pupil was 3 millimeters, single, circular, briskly reacting to light with direct and consensual light reflex present. On examination of the lens after pupillary dilation, a foldable, monofocal, posterior chamber intraocular lens was seen in the bag. It was well centered. The rim of the anterior capsule was opacified. The posterior capsule was intact with no posterior capsular opacification. On distant direct ophthalmoscopy, she had a peripheral red glow in the right eye and a red glow in the left eye. On examination with a 90 diopter lens and slit lamp, as well as an indirect ophthalmoscopy, the right eye media was hazy. The disc was hazily seen and appeared normal. However, details of the cup disc ratio, blood vessels, and foveal reflex were not appreciated. Fundus examination of the left eye with 90D and slit lamp as well as IDO was within normal limits. My provisional diagnosis was a right eye lamellar cataract with a left eye pseudophakia. On keratometry, the right eye revealed a 2 diopter corneal astigmatism. Intraocular lens power was calculated using ultrasound biomicroscopy by immersion technique and the SRKT formula. In the right eye, the axial length was 20.73 millimeters with an anterior chamber depth of 2 millimeters. The intraocular lens power calculation for a hydrophobic acrylic lens targeting emetropia was 27.5 diopters, and for a PMMA lens targeting emetropia was 28 diopters. Central corneal thickness was 558 micron with a white to white of 11 by 12 millimeters. In the left eye, the axial length was 20.69 millimeters with an anterior chamber depth of 1.95 millimeters. The intraocular lens power calculated in the pseudophakic acrylic mode for the hydrophobic lens was 26 diopters with a CCT of 557 micron and a white to white of 12 by 12 millimeters. We subjected this patient to routine blood investigations like a complete blood count, LFT, RFT, and BSL random. We found that the alkaline phosphatase was raised. Additionally, the serum calcium levels were slightly low, so we investigated this patient further. The serum phosphorus levels were raised. However, the albumin levels, serum vitamin D levels, serum parathyroid hormone, as well as TSH levels were within normal limits. We also tested for TORCH, IgM, and IgG antibodies, which were negative, and serology was negative. Urine routine microscopy was within normal limits. Our final diagnosis was a right eye idiopathic lamellar developmental cataract and left eye pseudophakia. We plan to do a 10% undercorrection for this patient as per the child's age, and the hydrophobic acrylic lens of 24.5 diopters was selected. Antibiotic drops were started 2 days before the surgery, and the child was operated under general anesthesia. A scleral groove was made 1 millimeters behind the superior limbus at 12 o'clock position. A 2.8 millimeter sclerocorneal tunnel was made. The first side port was made at 2 o'clock position, and the capsule was stained using trypan blue dye. A 5 millimeter anterior capsular excis was made using the Utratas forceps, and the second side port was made at 10 o'clock position. A thorough hydrodissection was done, followed by lens aspiration, and a single-piece hydrophobic acrylic square-edge intraocular lens was implanted in the back through the 2.8 millimeter incision. Post-operatively, she was kept on antibiotic eye drops 4 times a day for 2 weeks, steroid eye drops every 2 hours for 1 week and tapered over 6 weeks, cycloplegic eye drops twice a day for 4 weeks. Additional dietary counseling was done and calcium supplements were started as per the pediatrician's advice. This is the picture on day 1 post-surgery. The uncorrected vision in the right eye was 636, improving to 618 on pinhole. There was mild lid edema, conjunctival congestion, and corneal haze. Anterior chamber showed cells 1+ and flare 1+. The lens was in the bag, well centered. At the 2-week follow-up, in the right eye, her uncorrected visual acuity was 636 N18, improving to 612 on pinhole, with a refractive correction of plus 2.75 diopter sphere and minus 2.25 diopter cylinder at 180 degrees, and a near correction of 3 diopters. She improved to 612 N6, and intraocular pressure by GAT was normal at 14 millimeters of mercury. In the left eye, she had 636 N18, which improved with plus 2 diopter sphere and minus 1.75 diopter.
Can you sum up?
At 180 degrees to 69 N6, and IOP was normal. Anterior segment examination.
Just tell us the important findings here, because
Yes,
we want to discuss the case.
Within normal limits, the lens was well centered with no PCO noted, and the child was advised use of bifocals with left eye patching 4 hours a day for 6 days of the week, and a 1-month follow-up was given. Thank you.
Will you please stop screen sharing, Anisha? Yeah, thank you. So I request Hardipurkar sir to ask questions to Anisha. Anisha, congratulations. It was a very well presented case.
Thank you, ma'am.
Congratulations. Very well presented. Very well worked up case. Now just tell me any history of how long before this case this eye was the other eye operated, or was it bilateral to begin with? Any history?
So her history for both eyes was since 8 months, and she was operated in the left eye 5 months ago.
Okay, so that means you kept a gap of almost 5 months. One thing that I noticed here was that there's always a chance for amblyopia to occur if the two eyes are operated 2 different times.
Yes.
Yes. And what was the age of the child you said?
She's 7 years old when she was operated.
Okay. See, at 7 years, good enough. But then you have not looked at the cylindrical part. I mean, it is still possible that when you have such a big cylinder, I mean, cylinder is one of the commonest reasons why a person can develop amblyopia if the glasses are not worn. So you had a chance to put a toric lens. That is what I felt. You could have used a toric lens, and otherwise, I think everything has gone off well. Your under correction is also very appropriate. And maybe now we'll have to go through a little bit of more aggressive amblyopia therapy. And while you're talking now, has the amblyopia improved?
So we are yet to see her once again. We've advised patching for 1 month, and then we're going to follow her up so to see. And based on that, those improvements, so we may consider increasing the number of hours of patching.
What's your take on PC, Tommy? Like, what's the age that you decide not to do primary posterior capsulotomy? Because in a pediatric eye, when we do cataract surgery, it is a norm that we do primary posterior capsulotomy along with the cataract surgery. What's your take off for that? I mean, what's the cutoff age when you would not do PC-tomy and just leave it?
So usually if the child is above 9 to 10 years old or above, we leave the posterior capsule intact. Till 6 to 7 years, we choose to do a primary posterior capsular access with an anterior vitrectomy. At 7, 8, we can choose to do it without an anterior vitrectomy. However, son, this child, since she is very cooperative and we'll be able to do a YAG capsulotomy if ever needed, and she is on regular follow-ups, so that is why we chose to let the posterior capsule be intact.
What was the reason why the vision was the fundus normal in this?
Yes, sir.
Yeah. So the vision that's not improving is purely because of amblyopia. That's what you think? Yeah?
Yes.
I think you've done a good job.
Thank you, sir.
Minu ma'am, will you please ask some questions to Anisha?
Yeah, definitely. Very well presented, Anisha. That was a very nice presentation. Very detailed history taking. Actually, your history mentions it all, but could you please tell me the differentials that you considered in this case?
Yes, ma'am. Ma'am, since the child had come with a complaint of diminution of vision, which was gradual, painless, progressive, given her age, ma'am, first we did consider a refractive error. Second, we were, ma'am, considering mostly cataract plus her history of surgery in the other eye was strongly pointing towards it. A lot of our history was directed towards ruling out what was the possible etiology of the cataract before labeling it as idiopathic, ma'am, which is why we had asked a detailed history and worked her up, ma'am, for metabolic conditions, hypocalcemia, and ma'am, since there was no genetic history, neither siblings nor parents had it, ma'am, after ruling out everything, we've concluded it was idiopathic.
Was there any febrile illness during the pregnancy? Sorry, I missed that point in the history. Did you
No,
mention?
Yes, ma'am. There was no fever or rash. It was just the poor nutrition, ma'am, which was a concern.
What are the best ways to calculate IOL power in a child?
Ma'am, intraocular lens power calculation in a child, ma'am, we have to be very thorough with the keratometry and biometry. If the child is cooperative, ma'am, we can do a keratometry with a Bausch and Lomb keratometer, and additionally intraocular power calculation, ma'am, the options we have is an ultrasound biometer or an optical biometer. Ma'am, in ultrasound, we can do either applanation based or immersion based, and immersion is preferred. Since we didn't have an optical biometer, ma'am, we went with the immersion technique. However, if the child is very small or uncooperative, we can also consider taking them for evaluation under anesthesia, in which case, ma'am, an immersion would be the best option.
Now, in this case, did you do the surgery under local anesthesia or general anesthesia?
General anesthesia, ma'am.
Because sometimes the kids, even like at this age, some of them cooperate, but you never know because they are 7 and she's already operated one eye.
Yes.
So many times they are very cooperative. Maybe just with sedation also, it may be possible, but that depends. You can't rule out.
Yes.
Good. That was a very good presentation, Anisha.
Thank you, ma'am.
Anisha, what was the birth weight and for how long she was admitted in the NICU?
Ma'am, she was born with a birth weight of 1,000 grams, so she was very low birth weight, and she was kept in the NICU besides the mother for 1 month.
Okay. Sir, would you like to ask something regarding?
Just tell me one thing. If she was to present to you with both eyes phakic, meaning
Yes.
without the other eye being operated, would your approach be little different from this, or would it be the same?
So at this age, if she presented with a bilateral cataract, we would definitely plan the surgery as soon as possible. The eye with the poorer vision, we would operate first and operate the second within a few days of the first, if she was.
And with regards to undercorrection, what's the method do you follow? Because the child is 7 years old. At 7, would you still want to undercorrect the child?
So actually, as per, if we follow the calculation as per Dahan et al., so above 8, we can leave the child hemetropic. Since she'd fall in the 2 to 8 bracket, we went ahead with a 10% undercorrection. So additionally, if we calculate based on her axial length, so the axial length was also on the lower side. It was just around 20, a little short, higher than 20 millimeters. So which is why also we chose to do a little undercorrection. We're hoping that her axial length will increase a bit.
And with regards to lens options, do you have any choices, or would you still stick to monofocal?
So as you said, because of this high cylindrical power, toric could be considered, but so at her age, I mean, if she was maybe a little older, more than 10, but so in our setup also toric would be a little challenging. So we would continue with.
No, forget your setup. In general setup, like when I said the type of lenses, I wasn't talking about toric. Toric, obviously you must, but between monofocal and other lenses, do you have any option to put other lenses, or would you stick with the monofocal only?
So we could consider a multifocal, or we could consider doing a monofocal with monovision also for this child.
Why would you do monovision for here?
So she will also need near correction, and since she has a high sphere and the cylinder plus the presbyopic, the near correction, so for her, other than spectacles, contact lenses also she would need to be corrected each eye individually. And
now the thing is, in a child, it's not an exact science. You wouldn't know whether this child will have what kind of degree of myopization that will occur at the age of 18. So that means we are literally groping in the dark. And luckily you have a case with bilateral. Or one eye is operated, another eye you're operating. And you would always aim for one, you'll go for a monofocal lens, but if possible, you'll go with a toric. And I don't think it's a good idea to do monovision, because in any case, the child has to wear glasses and the refractive error is all the time going to change. and the child has to wear, progressive or a bifocal all her life or all his life. So I think the safe bet would be to give a monofocal or a monofocal toric. Definitely monofocal toric if the institute has a facility to do that, and try and get, because if you have toric lens on and you're done under correction, the child is wearing glasses, then you're putting the child through intensive occlusion therapy to kind of improve. And I'm sure, because the surgery is done well and the eye looks good, the patient will definitely come out of that amblyopia and will have good vision. So at that time, quality of vision matters more than what kind of a refraction the child has to wear. I think you've done it good. And whatever refraction the child has landed up with, it's pretty okay. You've done excellent job for the child. Well done.
Thank you, sir.
Minu ma'am, would you like to ask her something?
No, I'm done. I'm done. You can continue.
Okay. So congratulations to the mentors also for this good presentation and for the excellent surgery. With Hardipukka sir's and Minu ma'am's permission, can we move on to the second case?
Please, please.
Yes, please.
Sir, can we move on to the second case? Okay. Chalo. So the second case would be presented by Dr. Veeram, and her mentor is Dr. Charuta. She is a very good friend of mine. So Dr. Veeram to share her screen.
Am I audible, ma'am?
Yeah.
Good evening, everyone. Myself, Dr. Veeram Rajput, Junior Resident from Cooper Hospital. I thank MOS to give me opportunity present on cataract management in case of Marfan syndrome in a child. Informant being mother, a 9-year-old female, came to our OPD with chief complaints of blurring of vision in both eye, difficulty in mere work and outdoor activities since 2 years. Patient was apparently all right 2 years back and developed diminution of vision in both eye, right more than left, which was insidious in onset, painless, progressive since 2 years. She had history of spectacle use since then, there was a frequent change in glass powers, no history of any ocular trauma, redness, pain, photophobia, or floaters and flashes seen. She is a known case of Marfan syndrome with mitral regurgitation with mitral valve prolapse, which was diagnosed at the age of 7 years. Her maternal uncle had history of bilateral lens subluxation and scoliosis. No history of any mental retardation, thromboembolic events, or seizures in the family. No history of any similar eye conditions or connective tissue disorders from the paternal sides. No known consanguinity between parents, and she is a single child to the parent. Her birth history was normal with normal developmental milestones. Pediatric general and systemic examination was done. She was conscious, cooperative, well-oriented to time, place, and person, with no icterus, pallor, cyanosis, clubbing, or lymphadenopathy seen. Her central nervous system examination was intact and within normal limit. Cardiovascular system examination revealed murmur heard on auscultation. Respiratory system examination revealed pectus excavatum on inspection, and her per abdo examination was within normal limit. General examination for her Marfanite syndromes was done. She is a tall creature with positive arm span height ratio. Long and slender fingers were noted. High arc palate, pectus excavatum, hyperextensible joints, positive thumb and wrist signs were seen. On cardiovascular examination, mitral valve regurgitation with mitral valve prolapse was seen. Ocular examination, her head posture was normal. Visual acuity measured on distant and near Snellen chart in right eye was finger counting 3 meter, improving to 624 and N12. And in left eye was finger counting 4 meter, improving to 624 with N12. Her best corrected visual outcome was 624 with the acceptance of -10 diopter sphere with -5.5 sphere cylinder at 150 axis. And in left eye, it was -10 diopter sphere with -6 diopter cylinder at 20 axis. Orbit and adnexa in both eyes was within normal limit. Eyelid, conjunctiva, sclera were normal. Cornea was clear, transparent, and contour was flat. AC was within normal depth and quiet. Iris color pattern was normal. Pupil was 3 mm, central, circular, reacting to light. On dilated evaluation, lens was clear, subluxated inferotemporally as shown in the photograph. Phacodonesis was noted and zonules were absent in right eye from 12 to 5 o'clock and in left eye 7 to 12 o'clock. Intraocular pressure was measured on Goldman's applanation tonometer, which was 14 millimeters of mercury in right eye and 12 millimeters of mercury in left eye. Angles were open in gonioscopy. Extraocular muscle movements were full and free in all the gazes. On distant direct ophthalmoscope, crescent reflexing in both eye and posterior segment evaluation was within normal limit. Diagnosis of bilateral ectopia lentis secondary to Marfan syndrome with compound myopic astigmatism was made, and differential diagnosis in these cases are homocystinuria, which was ruled out as there was no mental retardation in child, Weil-Marsh syndrome, where the child has a short stature, and Ehlers-Danlos syndrome with multiple joint abnormalities are seen, which was not found in this child. On investigating further, systemic investigation was done, which all routine blood investigations were within normal limit, especially the serum homocysteines level were also within normal limit. 2D echo revealed mitral regurgitation with mitral valve prolapse, which further adds on to the Marfan syndrome's diagnosis. Ocular investigation was done with the measurement of axial length measurement, keratometry, and corneal topography was also done. IOL power calculation was done in the following way. K-metry was done on manual K-metry as well as on pentacam. Axial length measurement was done comparing immersion and optical both, where the IOL power was calculated in a phakic mode with A constant of 117.4 and Barrett's universal true formula was applied. The IOL power calculation was 18.5 diopter in right eye with the targeting E-metro, and in left eye it was 17.5 diopter targeting E-metro. Management was lensectomy with anterior vitrectomy and iris claw implantation under general anesthesia was done. Right eye was first operated, followed by left eye by the same surgeon. The post-operative outcome was patient had an uneventful recovery following the surgery. Best corrected visual outcome after 1 month of post-op was in right eye was 6.9 with the acceptance of plus 0.50 with minus 0.75 at 20 degree axis, and in left eye it was 0.50 with 1.7 with 1.5 cylinder at 100 degree axis with near add of plus 2.50 improving to N8. This was her 3rd month follow-up with both eye quiet, IOL in place, normal intraocular pressure with normal posterior segment. Marfan syndrome, it is an autosomal dominant genetic connective tissue disorder with near complete penetrance with variable expression. Mutation seen in fibrin 1 gene located on 15q15 to 21. Hallmark of zonular defects lead to the ectopia lentis, which occurs in mostly 60 to 80% of the cases. Visual dysfunction in Marfan syndrome is mostly due to ectopia lentis, refractive error, amblyopia, retinal detachment, cataract, and glaucoma. Ocular abnormalities in Marfan's are in anterior segment, we can find flattened corneas, astigmatism, megalocornea, glaucoma, poorly dilating pupil, iris coloboma, iridodonesis, and strabismus. Lens abnormalities include ectopia lentis, cataract, and lens coloboma. On posterior segment examination, there's vitreous liquefaction, abnormal vitreous attachment, retinal tears or retinal detachment, thin choroid, thin sclera, and long axial length. Ectopia lentis is usually diagnosed at the mean age of 5.8 years. The cause is fibrinal abnormalities, which leads to zonular weakness with lens subluxation. And the common lens displacement is superotemporal. It can be dislocated either anterior or posterior. Surgical indications are inability to achieve good corrected visual outcome, risk of amblyopia, posterior and anterior lens dislocation, lens-induced glaucoma or uveitis, and cataract formation. Biometric analysis in Marfan was done compared to adult and children. We have the higher prevalence of ectopia lentis in children. Surgical approach, we have 2 approaches, which is first is limbal lensectomy, which is best for anterior dislocated lens, but it is avoided in children less than 7 years due to immature pars plana. And complications are vitreous strand and anterior chamber hyphemia, and rarely we can find this membranes needing to the secondary arc. Pars plana lensectomy is usually preferred for the posterior dislocated lens, but it required a vitreoretinal centers. IOL selection, anterior chamber IOL is not preferred due to the risk of iritis, glaucoma, and corneal decompensation. Iris fixated posterior IOL chamber had good visual outcomes with complication of IOL dislocation, hyphema, and iris capsule. Posterior scleral fixated or posterior IOL had good long-term stability, but there's a risk of suture erosion, IOL tilt, decentration, and retinal detachment. Iris claw indications in the pediatric ectopia lentis is indicated when best corrected visual acuity is less than 20/60 with progressive subluxation, severe bilateral ectopia lentis affecting the pupillary axis, vitreous or anterior chamber dislocation or subluxation more than 7 clock hours, monocular diplopia, intolerance to lenses and spectacles. But the complications are IOL dislocation, de-enclavation are the most common. Pupil ovalization seen in mostly 60% of the cases. Transient rise in IOP due to pseudophakic pupillary block. Corneal edema, iritis, macular edema, and endophthalmitis are seen. Advantages are this surgery is simpler, shorter duration with shorter exposure to the general anesthesia and less hemorrhagic risk with compared to SFIL. Limitations are there are lack of randomized control trials and long-term pediatric data. Mostly observational studies are available, but we need more of interventional and long-term studies. Efficacy, according to the literature, most of the efficacies are comparable to the scleral fixated IOL, and most of the studies are statistically significant. The data shows that iris claw is effective in terms of improving visual acuity in pediatric child with ectopia lentis, but we further need a high-quality interventional studies and long-term studies. Thank you.
Will you please stop screen sharing, Viram?
Yes,
So that was an excellent presentation. But here we discuss cases which are usually asked in the exams. So that discussion part was not needed, but it was, of course, it was good part. So I request Hardipurkar sir to ask questions to Dr. Viram.
Hi, it's a good case, and it's very well done. The only thing I was just wondering, in both those eyes, when you showed that picture, I was just wondering, was there any other option other than lensectomy for that case?
No, sir. The other option was not possible because she was already not accepting her spectacles. So we
when you intervene, what is it that you really see? Is it the distant vision not correcting fully, or also the near vision?
sir, both distant and near vision.
And
She
let's say
noticed.
if that particular child was to have whatever vision she had for distance, but her near was still improving, would you wait for some more time or would you operate?
Sir, we would operate because risk of amblyopia and also the progressive disease, it may progress more, and we would need the more of the surgery. Say we would have to if it get dislocated into anterior chamber or say into the posterior chamber, then it would have caused more of the complications. Even children are more prone to trauma, so it would be the risky to wait and observe.
What are the incidents of a Marfan's or ectopia lentis case going into dislocation or anterior or posterior? What are the
according to the literatures, there's almost 50% of the cases, the Marfan's where the lens get dislocated, but not in the childhood. During whole of the adult age also, it included all adult and children also, sir.
Yeah, because in a child, the lens normally will not dislocate. So the fear of dislocation may not be the cause for you to operate early. You know, there are a lot of things that happen when you operate in a child. One thing, you know, the child sometimes, I mean, the moment you do lensectomy, the accommodation is lost.
Yes.
And you know, you're not sure of how much the lens power will change over a period.
Yes.
So that, I mean, sometimes some doctors, you know, prefer, you know, take an approach where even if the near vision is improving and the child is able to carry on with the studies, you know, they wait for a while because we know that, you know, it's a bilateral case, and because of you know, that ectopia lentis, the lens is kind of distorted, and there's so much of astigmatism which is causing all this amblyopia. The moment it's done and lens is put, the amblyopia, treatment is not very difficult.
Yes.
And second thing that I felt was you talked of anterior lensectomy and posterior pars plana lensectomy, but you never have kept an option of preserving the bag and fixing the bag. Because I think there are many centers where for a long, long time, people have preserved the bag, fixed the bag, and put the lens. I think that is also an option. Do you think so, or that's not an option at all these days?
Sir, in normal subluxation, we can keep, but considering
Marfan's.
Marfan syndrome, sir, as it is progressive. So if
Yes.
we try to put a CTR ring with posterior in back IOL, it may further dislocate with the IOL and CTR complex. So to avoid such complications, we decided to do the anterior vitrectomy and lensectomy.
But then this iris clips, suppose let's say the patient does get a myopic correction at a later date. What will
Yes,
be
sir.
your option? Would you do this and put a new lens? What is it?
No, sir, we will give her a refraction. We will give her the corrections as possible as we can.
No, because for an iris clip lens, which causes a lot of donesis, pseudophimodonesis,
Yes, sir.
in a child, the child has to live for all its lifetime. And that lens has to be held there well by the iris, which is also
Yes,
not very healthy. Sometimes people take an approach where they say, after the lensectomy, we would do a scleral fixated
Yes, sir.
and spare the iris. And in case at a later date, you still need to do some, secondary IOL or piggyback, you still have the iris tissue left with you, do incubation. These are different
Yes.
options. But I think you presented a case well. And what was the best correction after the surgery?
Sir, in right eye, best corrected vision was 6/9, and in left eye, it was 6/12.
And how many days it is since the surgery?
It was post 1 month follow-up, supposed.
So vision has improved.
Yes, sir, vision has definitely.
And have you put the patient on amblyopia therapy?
Yes, sir. She's on regular follow-up and she's being treated for the amblyopia therapy in left eye. Usually, the vision is less in left eye.
Good. Very nice. Very nice. But I mean, if I had to talk of my experience over the years, like in the days when we used to do this, I'm talking long back, we would always try and preserve the bag in spite of the understanding that yes, it's a progressive disease. But like if you have a pseudo exfoliation case, which is also progressing,
Yes.
and that's where we always preserve the bag and fix the bag.
Yes.
In this, the only problem here is if you have to fix the bag and be careful about the bag not falling down, maybe you have to fix it on either side. But again, like you say, it's true that it's a child and the child has to live for a long time. Even if you fix it now, even the suture is going to disintegrate within 8 to 10 years. And again, yeah, it's a very tricky situation.
Yes.
And the final decision, obviously, the surgeon has to take.
So depending upon the surgeon's comfort and the affordability of the patient, we have.
I think it's a nice thing you did. Good. Congratulations. Congratulations.
Sir, what is your experience in cases of Marfan syndrome? Sir, what do you do?
See, I have always preserved the bag. In fact, to the extent that what happens is, let's say the patient has come a little later and the bag is small and you have to fix the bag. My philosophy is a little different. I always fix the bag. And if I cannot put the lens in the bag because the bag is small and you already put an endocapsular ring and then you have to fix it. So there's hardly any place in the bag for the lens to stay also. At such times, I fix the bag and put the lens on the iris. Because, to me, if I can fix the bag, at least the posterior segment, it is not disturbing. That's my concern most of the time. But well, I think the bag is good enough to hold the lens also. And earlier you used to have that worry that if you pull the bag on one side with the segment, it may just give way on the opposite side. But either primarily or secondarily, you can always put a segment on the opposite side so that the bag is fixed on either side and the lens is staying there secure, and the posterior segment, posterior vitreous cavity stays undisturbed. I normally prefer that. But there are cases where, like you have long-standing Marfans where lens is as good as dislocated. There, of course, the lensectomy has to win. Now, if this case was to come to me, I would definitely try and preserve the back and put a lens in the back, because the extent of ectopi lentis was not much. But again, it depends on the comfort of the surgeon. But whatever has been done is done well. So, Dr. Manke, it's a good job.
Thank you, sir. Thank you so much. So, whenever we ask questions to Haripukar sir, he makes all the complicated things so easy, and we feel like just listening to you, sir. And so always, it's so good to listen to you, sir.
Thank you so much. Thank you.
Minu ma'am, would you like to ask questions to Dr. Veeram?
Actually, very nice case, Veeram. But after Haripukar sir has spoken about in length about this, and that too, I'm sure this is one of the main things, like the CTR segments and everything that he does. I think there is nothing else to ask about the segments. I'm sure sir would have actually put a CTR segment and done a different type of visual rehabilitation for this patient. I have one question to ask. Veeram, what do you think was the cause for the astigmatism? I think 5 diopters of astigmatism the patient had, right?
Yes,
What was the keratometry?
Keratometry showed, ma'am, the astigmatism of only 2 diopters in both the eyes. So mostly it was a lenticular astigmatism due to the subluxation.
Okay, and what
Which
about
was
the
further
retina? Yeah.
Fundus examination was normal, ma'am. There
How
was
do you
no
check
tilt
the
in the disc.
periphery? Yeah.
Yes, ma'am. There was no torsion, no tiltation of the optic disc.
What about the periphery? Did you look for the periphery?
Yes, ma'am. Periphery, we checked for the periphery. Peripheral retina was also within normal.
Okay. And any difference in IOL power that you put when you're putting an iris claw lens? Anything different from a PC
Yes, ma'am.
IOL?
We have to consider the effective lens position in this case, because it will be not in the bag. So we have to calculate, we have to adjust either the A constant, or with the effective lens position, we have to adjust the final lens dioptric power.
So what did you do in your case?
Ma'am, we adjusted the A constant. We used the universal Barrett 2 formula, and we have kept the child, we have targeted child E metro by using both the 2 parameters.
Okay. Okay, thank you so much. I think no more questions from my end.
Sir, do you operate congenital cataracts simultaneously, like both the eyes simultaneously?
Well, if the child is so small that anesthesia is a bigger risk, then I would operate both eyes. See, there was a time when I would put lenses at a very early stage, but over the years I have realized, and I have stopped doing that. I would operate, if it's a bilateral case, there's no urgency to put a lens at that time at all. So I would wait for 2-3 years, and after that only I may take the patient back for implantation. But it's always bilateral. It's always bilateral.
So, and what is your experience with the iris claw lenses, sir?
Well, one of the cutest lenses every surgeon must learn and put. They're so good. See the literature. There's so much of literature which says, well, you'll have this, you'll have that. But I don't think so. If you can put it well, it's truly a very safe and a nice lens.
What is your take on?
Come again?
What is your take on EDOF lenses in pediatric cataracts?
Come again? What's my take on?
EDOF lenses.
No. See, all said and done. EDOF, is not a monofocal. If you are looking at the quality, then I think monofocal scores over EDOF. EDOF will give you extended depth, but it's okay. So I would rather have, you see, for a child who has to wear glasses all their life, if they have to wear a progressive, and anyway they have to wear progressive and constantly, because the number is going to all the time keep changing. That means they are with the glasses. So I don't think I would put an EDOF. EDOF is a fancy lens for those for whom we only have taught the concept of extended depth. But otherwise, nothing beats a good aspheric lens. Monofocal would be my choice. Of course, but toric. I would always correct the toric, because that is also an amblyogenic factor in the optical system.
Sir, whenever a child comes to you with cataract, what all factors do you see for considering the implantation of the IOL?
Well, first and foremost, when the child comes, I only look at the ways in which I can postpone the surgery. If I see that child still has good amount of near vision, even if the distant vision is affected, I would still push it a little further, because a surgery is done well when the child is slightly bigger. But when a child comes with unilateral cataract and the cataract is advanced, you have still no choice at all. You have to operate immediately. And in that case, obviously, if the child is, if I see the patient's parents, they are capable of, fixing a contact lens, I would put the child a phakic and encourage the patient to put, use contact lenses, especially when it is uniocular. If it's binocular, bilateral cases, then I'm not really worried. I would operate them and put them on thick glasses, but I would always do more frequent checkups and under GA examination. My all cataract patients, I would do a lot of under GA examinations, and every examination, check their fundus, check their pressure, check their refraction. Because only today I was seeing a child for whom some 3 months back, we had given 18 diopters bilateral phakic glasses. And today when we check, the child was requiring 16 diopters. And I know maybe after a year, when we see the patient again, the refraction would come down. But frequent checkups and all they see in a cataract surgery in a child, my surgery may take very little time, but a lot of talking, a lot of counseling before the surgery, because I tell them what I do is 10% of the entire visual rehab, and 90% will be done by the mother. The mother has a very bigger role in a child's visual rehab. That is what I just impress upon them. And I also tell them, if tomorrow when the child grows up and sees well, the credit will not be to the surgeon or a doctor, it will be entirely to you, because you are responsible. Once you kind of prep them and prepare them, I think congenital cataract management becomes easy and good, efficient.
Sir, if you keep, can I ask a question?
Please,
Yes,
please,
yes,
please.
ma'am, please.
When would you prefer to put an IOL if you leave a child aphakic? And where do you put the lens? In the sulcus or in the back? Because
That's
a little bit difficult to
very
put in the
good
back.
question. That's a very good question. So what I do is I make a smaller XC. If you have to put a lens later on, you have to preserve the back, right?
Yes.
But you also have to do a posterior capsulotomy.
Yes, sir.
What I do is
Yes.
I make a smaller anterior axis and a smaller opening, meaning posterior capsulotomy, and leave the child aphakic. And then when I have to put, I go back and with the 26 needle on the anterior capsule, if you can make a circular opening and try and open the bag and remove all the soberings and all that, you still can put a lens, single piece lens in the bag, provided your posterior capsulotomy is small.
Yes.
And it's possible. It's possible. And otherwise, if that possibility is not there, then I'll use a 3-piece lens in the sulcus.
Yes.
Sir, till what age do you do the posterior capsulotomy, sir?
My cutoff is 6 years, like how the resident said, she said a nice thing. You look at the child, if the child can, in a year's time or 6 months' time, sit on the slit lamp or sit on the YAG laser for a YAG capsulotomy, I would keep the capsule clean. But in a child, in a very small child, I would do, posterior capsulotomy. There are two ways. Either you do primary posterior capsulotomy or with the forceps or with a cutter. If I have to do it with a cutter, I put the lens in and then go under the lens with a cutter and do it. If I'm not going to put the lens, I just have to make a posterior capsulotomy. I prefer to do it with the forceps. With forceps, you have a full control on a circular axis, because you need circular axis so that, later on when you're putting the lens, it's to your advantage. But if you have done it with a cutter, then it is irregular and it's difficult to put a lens in the back. So, but my cutoff is around 6 years, or if the child is mature enough, who can within 6 months also, if necessary, sit on the YAG laser.
Yes, sir. Sir, and what is your preferred management for, suppose for a 14-year-old child coming with refractive surprise of myopia of -6 or hypermetropia of +6? What would be your preferred management?
If at the age of 14, if his refractive surprise is properly managed with whatever method he's doing, I would wait till he's 18. At the age of 18, I look at one thing. If the primary implant is in the bag, my treatment of choice would be for a piggyback if the refractive error is big enough, which cannot be corrected with my LASIK. If it's normally there will not be a hyperopic surprise. It will always be myopic surprise. If the myopic surprise is to the tune of 3 or 4, you always have LASIK to manage it. If it's around 8, 9, 10, then it's either piggyback or lens exchange. Lens exchange is a more traumatic procedure. So piggyback, like day for yesterday, I was doing a case where the child I had operated when the child was 2 years old, not 2 years, 2 years old. And now the boy is 21 years old. And he had around -18. Now, -18, the choice was only between two, piggyback or lens exchange. I kept both the lenses. I told the patient, I may do piggyback if I have enough space between the iris and his lens. And to my horror, the lens that was put, I was all the time thinking, because one I had operated, the other I thought, obviously, I have operated. I hadn't operated. And in that lens, in that eye, there was a single piece lens sitting nicely for last all these years, but in the sulcus. The single piece of those days, in those days, the single piece was also used for sulcus, which had very thin haptic. It was sitting in the sulcus. If you have a lens sitting in the sulcus, you can't do it. So you have to do an IOL exchange. So that lens was removed and a proper 3-piece lens was put. And post-op, the patient was good enough. But I prefer to wait till 18. But suppose at the age of 14, his refractive surprise has not been properly taken care, and it has to be done to get his amblyopia out, then I may do the same procedure at 14. Because from 14 till 18, further surprise will be very minimal. So I'm not really worried.
Thank you so much, sir. And this was an excellent discussion.
Sir, one last question.
Yes, sir.
Sir, till what degree of subluxation you want to preserve a bag?
In a normal case or in a Marfan's?
In a Marfan's.
See, in a Marfan's, if I see a ectopia lentis where, when you have ectopia lentis, you have to judge two things, whether the donesis is more or it's normal. Because even if it is, let's say 6 o'clock, 8 o'clock, I would still fix it. And if I feel that the bag is small and by fixing it on one side, it's going to get a stretch on the opposite side, then I would fix another segment on the opposite side. But I would always fix if I can preserve the bag, because preserving the bag has a lot of advantages. So I think that's what I do. But then of late, I've seen when you have an ectopia lentis, the patient straightway goes in for a lensectomy, because every VR surgeon would prefer to do a lensectomy. But we are, people with old school of thought. And so I still prefer to do, prefer to preserve the bag. I may be wrong also, but so far, in all the cases that I have done where I have preserved a bag, I haven't seen that child getting any complications over the years.
Yes.
There might have been, but I have not been able to see them. Sometimes they come to you follow, sometimes they don't. But I don't know.
Thank you.
Okay, thank you so much, sir. And I thank Minu ma'am also for being the faculty in this webinar. And I thank Dr. Anisha and Dr. Viram. And I really thank Dr. Charuta for mentoring Dr. Viram and Dr. Bangal ma'am and Dr. Shobna ma'am for mentoring Dr. Anisha and presenting excellent cases today. So I request Thorat sir to give
Yes,
the
it's okay. Okay. Most importantly, both Anisha and Viram, they not use short forms during their presentations.
Thank you, sir.
Okay.
No, they were good, huh? Congratulations.
Congratulations to both of you.
Yeah,
Yes,
very
yes,
nice.
yes.
Both of you
Very
were
nice
very good.
presentation.
They are very,
Thank you, sir.
very confident. And thank you. Hats off to their mentor for all the hard
Yeah,
work.
compliments to their teachers.
Yes, yes. And great inputs from all experts. It's like a PG class taken by Hardipurkar sir.
Yes,
Yeah, we
yes.
are. Yes.
Such
Yes.
good discussion. Such good discussion.
Actually, yes, yes, we all learned FECO by watching his videos in the 90s. Thank you, sir. Thank you so much. Thank you, everyone.
Thank you so much.
So
Thank you.
thank you. Thank you so much.
Thank